We've been using coblation technology for several years now with very good results to perform intracapsular tonsillectomies. The patient that we'll be doing today is using the Coblator 2 device with the EVAC TNA wand. We are going to be performing bilateral intracapsular tonsillectomy using the EVAC TNA wand. Here's the EVAC TNA wand tip, and we're starting off at an ablate setting of 9 and a coagulate setting of 5. So you can see over here that the technique is that you need to hover over the tissues, and you do not want to embed the tip into the tissues, and there needs to be constant motion of the tip of the wand. I'm over here, I'm using kind of a scooping motion here, and what you're trying to achieve is you're trying to achieve a saline interface between the tip of the wand and the tissues. All of the plasma ablation occurs within the saline interface. Now, as long as you maintain an effective saline interface, you won't get any clogging of the device. And if you experience any clogging of the device, it just means that you're not providing an optimal saline interface. The position where you start from doesn't matter as much, although the way that I usually do this is I usually just start from the surface of the tonsil and I go inwards. The patient advantages of intracapsular tonsillectomy are that there's reduced postoperative pain, less frequent use of narcotics, less incidence of postoperative nausea and throat swelling, with a quicker return to normal diet and activity. And I think this is achieved because there's less depth of thermal injury to the adjacent tissue and resulting in faster healing of the tonsillar fossa. I've demonstrated this in a randomized double-blinded study comparing intracapsular coblation tonsillectomy to electrocautery tonsillectomy. This Heard retractor can be used to move the tonsil around so that you achieve a more efficient interface between the tip of the device and the tissue that you're trying to remove. You can see that this coblation handpiece is actually quite efficient at ablating the tissue in a very speedy fashion. As water accumulates in the back of the throat, you can suction it up, and that also helps prevent clogging. I'm using the Heard retractor here to retract the pillar to try to identify as we're getting closer to the tonsil capsule. And as we're getting closer to the capsule, we will turn the ablate setting down from 9 to 6. Now, when you turn it down from 9 to 6, a few things occur. Number one, the ablation becomes a lot less aggressive. So it removes a thinner portion of tonsil tissue at a time. The second thing that happens is you actually get better coagulation at lower settings. So at the higher setting, you get much more aggressive ablation and less coagulation. And then at the lower settings, you get slower ablation and more coagulation. So here we're retracting the tonsil pillar. And now what you're trying to create is you're trying to create a concavity, the actual concavity of the tonsil fossa, without penetrating through the capsule. Now with coagulation, the tip is actually applied to the surface that you're trying to coagulate, and you're actually in contact with the tissue as opposed to hovering over the tissue. And what we're trying to achieve here is removal of 95 to 98% of the tonsil bulk, leaving the thinnest portion of tonsil over the capsule. to protect the capsule from being penetrated. So we're going to move to the other side right now. So I'm going to turn it back up to 9. Again, a hovering motion, hovering over the tissues, keeping the tip in constant motion to maintain your saline interface. When you do this correctly, you never have experienced any clogging, and you also, as you can see here, there's no bleeding. Well, you get very precise tissue removal in comparison to the microderbeater. Simultaneously, you get good hemostasis throughout the procedure. And in fact, many times when I use the coblation, I don't really have to do much coagulation at all at the end. Whereas when you're using the microderbeater, you end up coagulating almost the entire surface. For intracapsular coblation, once you know kind of the technical fine points, it shouldn't take many more than 10 cases to become comfortable. One thing about teaching this technique, though, I'm very reluctant to teach the intracapsular tonsillectomy technique to residents who have not done a subcapsular tonsillectomy. I think in order to do a good, complete intracapsular tonsillectomy, you have to be very, very familiar with how to dissect a tonsil out subcapsularly. And so, before teaching residents how to do intracapsular tonsillectomy, I make sure that they're very experienced at doing subcapsular excision. And the reason for that is it takes a certain level of experience before you can visualize where the capsule should be on each patient. And it's very easy to leave a lot more tonsil than you want to leave behind if you're not aware of where the capsule is. For a surgeon who's already experienced with tonsillectomy, who's done many tonsillectomies the old traditional way, that shouldn't be a problem. And here's the concavity that we're trying to achieve. We're getting closer, so I'm going to turn the ablate setting back down to 6. And I turn the ablate setting down to 6 when I think that I'm getting very close to the capsule. And we just use the lower power setting to remove the very last final layer that's over the capsule. So this is the completed intracapsular tonsillectomy. I'm going to retract this pillar and you can see the concavity of the tonsillar fossa. The capsule has not been violated. And then we're going to look on this side, and again, here's the concavity of the tonsillar fossa. This tonsil bed here looks nice and clean, nothing to do. Now we're going to inspect the other tonsil bed, and that's nice and clean.